Assalamualaikum. Good morning, everybody. Welcome to this free paper session. And with me, Dr. Hajra, she's the co-chair, and we'll be going through this. We have like how many papers? We have one, two, three, about 8 papers, 8 talks. And to start, I'd like to invite Dr. Ali Hassan, and he'll be presenting his paper, Outcomes of Amphotericin B azoles and echinocandidus in Candidemia, a retrospective study from a quaternary care hospital in Pakistan. Thank you. Dr. Hassan, you've got 10 minutes, and we'll ring the bell at 1 minute to mark you over the last minute. Thank you.
Bismillahirrahmanirrahim. Good morning, everyone. My name is Ali Hassan, and I am a resident pharmacist at Shifa International Hospital. This project has been supervised by Dr. Shahnila Javed, who is an infectious diseases consultant at Shifa International Hospital. Well, the study that we have conducted is about candidemia. The topic of our study was the treatment outcomes of amphotericin B azoles and echinocandins in candidemia, and it was a 3 years retrospective study that was conducted at Shifa International Hospital. So if we move next and if we talk about the background that why we conducted this study, what was the need of that study? So there were many points that we considered. Like let's suppose we talk about the mortality. It is reported that mortality is increasing day by day. By candidemia, it is reported that almost 30 to 60% of the mortality is because of the candidemia. And there were many other points that motivated us to perform that study. If we see that the data from Pakistan is very limited about candidemia. We are following the international guidelines. We are following the international guidelines about the candidemia, that what antifungal should be given, but we don't have the local data. So that was the motivation of us to perform that study. Similarly, there is a shift from Candida albicans species to other species, and the other species that we are reporting, they are more resistant to antifungal treatments. So a study has reported that globally, the incidence of candidemia is estimated at 5 to 10 cases per 1 lakh population annually, with mortality rates reaching up to 60% despite antifungal treatment. So, अगर मैं sum up करूं इस सबको, तो I would say कि mortality is increasing, hospital acquired infection इससे बहुत ज़्यादा बढ़ रहे हैं. उसके बावजूद पाकिस्तान का कोई ऐसा डेटा या ऐसी स्टडी नहीं थी जो हमें ये बता दे कि which antifungal is best in our population. So that's why this study was conducted. If you talk about the objective, primary objective हमारे पास 7-day fungal clearance था. We wanted to see कि कौन सी antifungal जो 3 groups हमने चुने हैं उनमें से कौन सी antifungal जो है वो fungal clearance दे रही है 7 day के अंदर. Then the secondary objective was 14-day mortality, 30-day all-cause mortality, and 90-day readmission. If we talk about the methodology, it was a retrospective study, as I mentioned earlier, a 3 years retrospective study. The time frame was October 2021 to December 2024. We retrospectively analyzed 112 adults जिनको blood culture confirmed candidemia था. Patient 3 ग्रुप्स में डिवाइड हुए थे. एक ग्रुप को एजोल्स मिल रहा था, एक को अकाइनोकैंडिन्स, एंड देन द थर्ड वन वाज रिसीविंग एम्फोटेरिसिन बी. सो द प्राइमरी आउटकम वाज 7-day fungal clearance. Secondary outcomes include species distribution. We wanted to see the prevalence as well, कि कौन सी species की कितनी prevalence है. Similarly, 14 and 30-day all-cause mortality and 90-day readmission or reoccurrence. So descriptive and analytical statistics were performed using SPSS soft version 31. If we talk about the inclusion and exclusion criteria, this study was performed on the patient older than 18 years. They have blood culture positive for Candida species, and they received one of the study antifungals for the duration more than 48 hours. And the data for outcomes are available for primary as well as for secondary outcomes are available. Then we will include it in inclusion criteria, otherwise not. Exclusion was if the age is less than 18, treatment discontinued within 48 hours and inadequate information for analysis. So we actually screened 204 patients and 112 met the inclusion criteria. with treatment distribution as echinocandins patient, 52 of the patients received echinocandins, and echinocandins we have the caspofungin. The only drug that we have in our hospital is caspofungin. So 52 patients received caspofungin. In azoles, there were two drugs, voriconazole and fluconazole. So 37 of the patients received azoles, and amphotericin B, 23 patients received amphotericin B. If we talk about the descriptives, so the median age in our study was 57 years. Male-female ratio was 62% were male and 38% were females. And median therapy duration was 10 days. Range was 10 to 21. 7-day fungal clearance was obtained in 48% of the patients. 14-day mortality was achieved in 28% and 30-day mortality in 42%. I would clear this that this data is 7-day, 30-day, and 14-day and 30-day. It's because of all the drugs. Like जितने भी 3 ग्रुप्स हमने दिए हैं, उन सब की वजह से क्लियरेंस जो ऑब्टेन्ड हुई है 7-day फंगल क्लियरेंस वो 48% है, 14-day मोर्टेलिटी 28% थी, 30-day मोर्टेलिटी 48% थी. इसके बाद जो नेक्स्ट अपकमिंग स्लाइड्स हैं उसमें सेपरेटली भी हमने देखा है कि हर एक ग्रुप में कितनी मोर्टेलिटी आई है और कौन सी ड्रग ज्यादा इफेक्टिव थी. So 90-day readmission was 21%, like 61 survivors में से 13 ने 90 डे के अंदर अंदर दोबारा हॉस्पिटल में उनका एडमिशन हुआ. Risk factors, we all know that risk factors जो contribute करते हैं candidemia को, there are many risk factors, but we chose these ones that are very important. Central venous catheter was one of the highest major risk factor. 51% of the patients were on central venous catheter. ICU stay was in 54%. TPN was in 35%. Recent surgery was 29 and chemotherapy 16%. और इसमें से काफी ऐसे पेशेंट्स थे जिनको एक से ज्यादा रिस्क फैक्टर्स थे, एक से ज्यादा रिस्क फैक्टर्स कंट्रीब्यूट कर रहे थे. If we talk about the analytics, so basically हमारे 2 टेस्ट हमने परफॉर्म किए थे, chi-square test and man-Whitney test. If we talk about the ICU stay, chi-square test was used, and statistically it was significant because p-value was 0.05, and ICU admission, we noticed that ICU admission was associated with higher 30-day mortality, because we know there are multiple risk factors that we studied in the previous slide, that ICU stay is a risk factor for candidemia as well. Similarly, time to antifungal initiation, ये एक बहुत इंपॉर्टेंट पॉइंट था कि जितना डिले थेरेपी हमने स्टार्ट की उतने आउटकम्स हमारे बुरे आए और उतनी 30-day मोर्टेलिटी ज्यादा हुई. इसमें we performed man-Whitney test because the data was skewed, so we applied non-parametric test and the p-value was 0.002. It was also significant, and we find out that delay antifungal treatment independently predicted higher mortality. Similarly, if we talk about the species distribution, कि कौन सी species सबसे ज्यादा prevalent थी, so या किसमें mortality सबसे ज्यादा थी, तो mortality was highest in Candida auris and Candida krusei infections. Similarly, antifungal.
Dr. Ali, you got 1 minute left. 1 minute to go.
Yes, sir. Antifungal, if we talk about the antifungal class, echinocandins versus non-echinocandins, the data was statistically significant. So if we sum up this slide, the tests that we have performed there all were statistically significant. So the study is statistically significant as well as the clinic, it is significant clinically as well. Results की अगर हम बात करें तो mortality अगर आप individually देखें तो वो जो 52 पेशेंट्स जिन्होंने इकाइनोकैंडिन्स रिसीव की थी उनमें 14-day mortality was 22% and 30-day mortality was 26%. सिमिलरली एजोल्स की बात करें तो उसमें 50 to 57% है. सो ये यहीं से हमें प्रूव करती है कि इकाइनोकैंडिन्स वाज अ बेटर ऑप्शन और उसकी एफिकेसी ज्यादा थी. कंपैरिजन की बात करें तो इकाइनोकैंडिन्स ने 47% ऑफ द पेशेंट्स में माइक्रोबायोलॉजिकल क्लियरेंस अचीव की, एंड एजोल्स की बात करें तो उसने 22% में माइक्रोबायोलॉजिकल क्लियरेंस अचीव की है. This was the conclusion. A kinocandin-based therapy achieved 47% fungal clearance. Obviously, it's a better option with the lowest 14-day mortality. With delayed antifungal initiation, markedly increased 30-day mortality. तो जितना डिले करते हैं उतना mortality increase होती है. कुछ limitations थी हमारी स्टडी की. सबसे पहले ये थी कि सिंगल आर्म रेट्रोस्पेक्टिव स्टडी थी. सेकंड ये थी मॉडरेट सैंपल साइज था, तो इतनी जनरलाइज नहीं कर सकते हम इसको. पोटेंशियल कंफाउंडर्स काफी ज्यादा थे इसमें, दैट वी हैव ट्राइड विद लॉजिस्टिक रिग्रेशन को उसको रिमूव किया जा सके, लेकिन स्टिल इसमें काफी कंफाउंडर्स थे. So that was all about my study. If you have any questions, you can ask.
Thank you very much.
Thank you so much.
Do you have any questions? Okay, I have a question.
Yes.
So in the beginning, you mentioned that, there's data lacking from Pakistan, and that's one of the reasons for doing the study. So how much, conformity you find in Pakistani data as compared to the regional and the international data?
So would you please repeat it? I couldn't hear you.
What I want to know is that now you have results from Pakistan.
Yeah.
Are they similar or dissimilar from the international data?
They are quite similar to the international data. Like
Right.
if we see the international data, they say the caspofungin is the better option and it has the lowest mortality in 14-day and 30-day. Similarly, the data we found that also shows that echinocandin is the better option.
So what difference is it going to bring? Is this study going to bring?
So
If it's similar to the study that's been done outside, so what are you telling your reader
so sir,
by doing this study?
जी सर इनिशियली हमें इस बात का आइडिया नहीं था that if we are using the international guidelines whether the local data or the local pattern follows that trend as well. So इस वजह से ही परफॉर्म की गई थी कि हमारी जो पॉपुलेशन है वी ऑल नो दैट हमारा रेजिस्टेंट पैटर्न डिफरेंट है. हमारी पॉपुलेशन के अंदर क्या ये एंटी फंगल ट्रीटमेंट्स जो हम दे रहे हैं क्या वाकई वो उसी तरह अफेक्टिव हैं जिस तरह इंटरनेशनली अफेक्टिव है या इंटरनेशनल डेटा जो हमारे पास अवेलेबल है. एक तो हमारे पास ये था कि एक डेटा बेस हमारे पास आ जाए. ऑब्वियसली इस पे मजीद स्टडीज हो सकती हैं इस पे जैसे मैंने बताया क्योंकि ये मॉडरेट सैंपल साइज था इससे ज़्यादा सैंपल साइज हो सकता है. तो हमने एक पैटर्न देखना था कि क्या एंटी फंगल्स जो हमारे पास हैं या प्रिवेलेंस जिन स्पीशीज की है क्या वो हमारी पॉपुलेशन में भी वैसी है या नहीं है.
Okay, thank you.
थैंक यू सो मच.
So now I would like to invite the second speaker, Shahzadi Resham, and she'll be presenting about navigating the landscape of pediatric hematological malignancies, a qualitative exploration of the caregivers' experiences and palliative care integration.
Assalamu alaikum, everyone, and good morning. Thank you so much for the opportunity. I have nothing to disclose. So, palliative care prevents and alleviates physical, developmental, psychosocial, and spiritual suffering in patient and family facing life-threatening illnesses. Early involvement during hematopoietic cell therapy clarifies goals promoting advanced care planning, enhancing quality of life, including relapse disease post-marrow transplant patients. Evidence showed that their consultation improved care satisfaction, symptom management, communication, early recognition of prognosis to support coordinated care. Despite evidence supporting early integration, its presence in hematology oncology remains inconsistent. WHO advocates for early integration as an ethical responsibility. However, in Pakistan, over 10,000 children got diagnosed with cancer annually, with leukemia being the most common. These cases present challenges in symptom management, prognosis, and caregiver burden. However, in Pakistan, the palliative care is nascent, not as a national priority, constrained by limited infrastructures, resources, trained personnel, and context-specific evidence. And there is limited knowledge of how parents of children with hematological malignancies in Pakistan navigate care, cope with their illnesses, challenges, and perceive palliative support. So, in order to address this, we aim to explore the experience and perspective of parents and caregivers of children with hematological malignancies in Pakistan, focusing on how they navigate care, cope with illness related challenges, and perceive the role of palliative care. And the study also seeks to identify the unmet needs to inform strategies for improving palliative care delivery and support for affected families. So the study was conducted in the pediatric oncology unit of Aga Khan University Hospital, approved by ERC committee. Participant included parents or caregiver of children between 0 to 18 years diagnosed with curable or incurable hematological malignancies who had integrated palliative care in their treatment plan some way or the others. Caregivers were eligible if they were fluent in English or Urdu and able to attend the in-depth interviews. It was a qualitative phenomenological design. Purposeful sampling was used to ensure the diversity in caregivers' perspectives, taken into account child's age, diagnosis, and palliative care integration. Data was collected through semi-structured, in-depth interviews. Interview guide included open guided questions which were developed from international literature, refined with the input from the local expert, and piloted for the culture appropriateness. Participants received verbal and written information about the study, and recruitment continued until the thematic saturation was achieved. So themes were organized using Dido software. Qualitative study reported in accordance with the correct guidelines for reporting qualitative research. And given the sensitivity of the subject, the psychological support was also offered to the parents and patients. So, 9 families participated, represented by 7 mothers, 5 fathers, and 1 non-parent guardian. 4 interviewed involved both the parents. Children diagnosis included B-cell lymphoma, leukemia, with or without relapse, non-Hodgkin's lymphoma, and chronic myeloid leukemia. Mostly patients were between 13 to 18 years of age. Male and female ratio was almost equal. There was primary B-cell leukemia. There was relapse leukemia. There was CML and Hodgkin lymphoma. 4 interviewed included both the parents, and majority of the patients were living at home with their nuclear family only. Majority were given palliative care consult considering their emotional support, followed by symptom management, caregiver training, and financial support. However, the suffering involved in majority was psychological, followed by physical, social, and spiritual. So 4 themes were emerged after the interviews. First was psychological suffering with a sub-theme of parental distress and the imperative to remain emotionally composed. Caregiver described the emotional labor of sustaining calm in front of their child while privately experiencing significant psychological strain. Father of a 14-year-old child said that I have learned you have to face everything and you should not panic. If you keep stressing, what's the point? I put my phone on flight mode, play with the kids, watch TV, and then he's unwell. It's okay, he's in God's hand. The other sub-theme of the psychological suffering was complexities in parent-child communication. Parents have described a tension between protecting their child from distress and honoring a moral imperative to be honest. Avoidance of information often created emotional distress and was compounded by a lack of preparation of such conversation. Father of CML 16-year-old child said, "We did not tell him in the beginning, and even now he does not know from our side." Often of course, he knows. He just does not cuss it. Nowadays, you open Google and you have the whole world. I do not have the courage to talk about it with him. And then there was a sub-theme of caregiver hypervigilance anxiety, describing all encompassing sense of responsibility that demanded sustained vigilance and often came at the expense of their own autonomy, rest, and emotional well-being. Mother of B-cell ALL leukemia of 14-year-old said that I'm most afraid. That's why I don't let my daughter touch the medicine. She's not even allowed to handle them. I do myself everything. Even when she goes to the bathroom, I cannot leave her alone. I manage everything myself. Then there was a theme of social suffering, including disruption to daily life and routine, where the parents have noticed their routine has been not disrupted but has been difficult to manage. One of the mothers said that people do help financially, but the fact is we are unemployed. As long as the treatment continues, we have to stay put. I'll try to go out for work even just for 1 or 2 doses. His condition worsens. The next day he has intense pain or some complications. And out of that social suffering, there was a sub-theme of diminishing social support and emergent isolations. Parents who have come from far areas do not have enough support in their treatment process. One of the mothers said that all my relatives are in Peshawar. I live alone here. So I have done everything on my own, coming and going, the hospital visits, all of it all. And then parents have talked about their sacrifices and the marginalization of siblings, which emerge as quite but painful tension. Parents often spoke about noticing their other children behavior change without knowing how to recenter them. One of the mothers said that my younger son academic performance was very poor this year. My younger child became very stubborn. He refused to go to the school. My older son withdrew himself. He doesn't share anything with me. And then there was a physical suffering theme, talking about the challenging symptom management and identity of the loss. One of the mothers said that she loved her hair deeply. She loved how long they were. When the hair loss started, she became mentally disturbed, talking about the challenges resulting from the illness and treatment. And then there was a last theme about spiritual and existential suffering. Parents have felt about having a fear, a way to channel their fear into hope and regain a sense of control over unpredictable situation. One of the mothers said that I have forgotten what my own life is. From morning till night, I recite prayers for my son. Yes, there is treatment, but there's also great blessing in the words of God. So In conclusion, caregivers of children with life-limiting illnesses in resource-limited setting face complex challenges at every level. Culture-appropriate, family-centered care that includes mental health support for parents and attention to sibling can help address the suffering experienced by families even in resource-limited settings. So early integration of comprehensive palliative care services addressing caregivers' emotional, practical and spiritual needs while improving communication can enhance outcomes for both children and their families. Thank you.
Thank you for the nice presentation. Do we have any questions from the speaker? Okay, I can ask one thing. This was a small group of families, but of course it was very comprehensive. Are there any regional data for a similar study? Regional, I mean, like subcontinent and this area.
I think this is an excellent question. So, as far as the in-depth interview and their lived experience is concerned, there are data around in the literature, but not specifically talking about the hematological malignancy and specifically about the children going through this trajectory of illness. So that's why we wanted to find out that whether this has any difference than any other malignancy or the needs are similar in children dealing with hematological malignancy versus solid malignancies. But specifically in this topic, there isn't any regional data out there in the literature.
And one other thing, that generally the outcomes of hematological malignancies is improved over the decades, especially in children as well. So these are probably somewhere in the middle of the treatment. Do we have, or you plan to have study when, when kids are cured, how does that improve the overall stress
So
level
I
for the family?
think this is a great and excellent suggestion because this was the initial study to find out the lived
Yeah.
experience. And maybe we cannot follow these, but
Yeah.
while I am and we are providing that care in our hospital,
Yeah.
we can certainly find out what the role of palliative care or providing these services have made throughout the course of illness. Yes, that would be a good study. Thank you.
Looking at this study, the sample size. So, do you think it was enough?
So-
Just
Yeah.
nine?
So what happens in qualitative study, because there isn't any set sample size to begin with, and you have your topic guide in front of you with the questions, and you go by interview, and whenever you reached a saturation point when there isn't any new information coming out from the interviewee, so you stopped over there. So we took consent. Whoever consented, we took them as an interviewee and started interviewing them. And wherever we found out that now we have received so much information which is coming out similar, and that's where we blocked our interviewing process. And I think this happens in qualitative study, and the results depend upon what are you getting out of these interviews. Are they making any sense as far as the context is concerned or not?
So, were these the children who were referred to palliative and then you interviewed them?
So what happens in our center Ed, is now we have started early integration with high-risk leukemias and the ones who are admitted with relapse of leukemia. So the team was already integrated throughout the process. Although the team has only one physician, who am I, and there are nurses which I'm getting in help from an adult team. So it's not a full-fledged team, but there's some sort of palliative care in terms of relieving suffering. Like if I'm providing palliative care, so I'm wearing a hat of a social worker, I'm wearing a hat of a psychologist, I'm wearing a hat of a physician. So we wanted to find out that how can we generate a need of a independent psychologist there or a spiritual healer in our setup so that we can show data to our hospital or maybe in our country that this is a need for our patient which will be there.
Okay, thank you.
Thank you.
Okay, thank you. Now we'll move to the third speaker. I would like to invite Muhammad Abdullah, and we'll be talking about respiratory complications and rehabilitation after esophagectomy and esophageal carcinoma retrospective analysis.
Assalamu alaikum everyone. Assalamu alaikum, everyone. Hi, I'm Muhammad Abdullah. I'm a respiratory therapist, PhD scholar, and I'm the register from National Board of Respiratory Care, USA, and active member of European Respiratory Society. Today, I'm going to present my topic. The topic name is the respiratory complication and the rehabilitation after esophagectomy in the esophageal carcinoma. Where we had to go? Yeah, this one. So introduction is that, so main thing that esophageal carcinoma, here we look that is the main burden on oncology settlement. This is basically what will happen that it's the seventh most diagnosed cancer and sixth leading cause of the cancer among worldwide. Annually, when we look in the data, 0.51 million new cases annually and around about 0.45 million deaths annually happen due to esophageal carcinoma. So esophagectomy is the main treatment of esophageal cancer. And in this next, so our topic is main concern is the pulmonary complication, respiratory complication associated with esophagectomy. Post-operative pulmonary complication, around about 60% associated with respiratory failure and increase the mortality and also cause mean an ICU stay. The reason that behind atelectasis and then lobar pneumonia, secretion retention, impaired cough reflex, and this leading to acute respiratory distress syndrome. Post-operative respiratory complications significantly influences recovery, hospital stay, mortality, and the survival. Structured respiratory therapies is essential to improve the outcome. What is structured respiratory therapy? This is given by trained respiratory physiologists or therapists. This is inspiratory maneuver, expiratory maneuver, some chest vibration, oscillatory therapy, and cuff technique, and some other stuff like nebulization, and you are performing the bronchial hygiene therapy. So objective of my study, this is the background. Objective of my study is that I'll evaluate the respiratory complication and outcome after esophagectomy. So second outcome determine the role of the respiratory rehabilitation in reducing the pulmonary complication. Assess impact on recovery and discharge mobility. So study methodology is that it is cross-sectional study. Basically, it's a preliminary data. We have the preliminary data, and this data is consisted on the 60 patient only. And 60 patient, and after that, the sampling technique we use that this is a proportion sampling, and this is esophageal carcinoma underwent esophagectomy and single tertiary oncology center. This is our study target population. So 6 month study, we have started 2025 to onward. This is a basically plan of our methodology. So our methodology esophagectomy, that this is a patient factor, surgical burden, cause the complication, and cause the respiratory. And this after that, we did the intervention. This is the respiratory rehabilitation. And after that, we have measure the outcome regarding the survival rate, regarding the ICU stay and a hospital stay, and overall the reduction of the pulmonary complication. So result, first we have result is that this is a demographical data. So our study included 51% male and 49 female. So graphically, this is the display. The pie chart shows overall the situation. And another that we have find about the gender with squamous cell carcinoma. And squamous cell carcinoma, 59%, and then a male, and then 41% female have the basically we get this cancer. Another is that adenocarcinoma. In due to the adenocarcinoma, the male is 82% and only female is 18%. So male have high risk to develop the adenocarcinoma. So age, when the age, look at the age, our is the 42 and plus minus 7, BMI 20 plus for the minus 4. The BMI is low because due to esophageal cancer, patient has poor intake. That's why there's a variation in the body mass index. So this is the overall the graphical display of our age and BMI, which is showing that BMI is around about 20 and plus minus 4, and then the age is our. So duration of the surgery. So when we have looked into data, the duration of the surgery, the median, we have calculated the median. So median is around about 360 minutes of surgery for this, our study. In preoperative patient, we have first profiled the preoperative file. And in this, we have found that hypertension is 22%, diabetes is 80%. This is basically the patient with esophageal carcinoma already had some comorbidity, and we have profiled them. So this is, and then we have looked at the tumor and the surgery type. So when the surgeon they have did the surgery, so 45% patient had tumor involved in lower third region, and 35% middle, and 20% has upper side. And this is the squamous cell carcinoma, and the comparison tumor location squamous cell carcinoma and the tumor location an adenocarcinoma. When you look the data, it tells you about the graphical trend. The tumor located squamous cell carcinoma is lower region, and tumor in the adenocarcinoma is located in the upper region. So pre-operative respiratory rehabilitation. So what we have did that we have coached each and every patient regarding this respiratory rehabilitation program. And in this, and when we have noted there are some complication. So when we look at the graph in the complication, you have looked at, we have main problem is secretion retention. Then we have problem atelectasis, and then impaired cough level. So these are the main reason the patient develop respiratory complications. And if we have compared the squamous cell carcinoma, adenocarcinoma, this also show that secretion retention, the both group have the problem. And after that, we have checked the association with gender, and we found that in the gender, when you look in the gender, in the female, the secretion retention, and also in the male group, both have the, but in the female group, atelectasis is more common as compared to other group. So gender is associated with the complication, and male has a more as compared to, and female has you have atelectasis. And body mass, when we have looked in another parameter, the body mass index, the group which has body mass less than 18, they have the more prominent with the pulmonary respiratory complications. And airway, when we look in the airway, so in the airway during anesthesia, they are using the double lumen tube and single lumen tube. And double lumen tube, they have using that, they have more complications as compared to single lumen tube. So this is also risk, so gender, BMI, and then this is the third our risk factor. So respiratory rehabilitation, we have planned, these are the 90% incentive spirometry, we have started CVT 100%. And after that, we have noted, so we have noted what will have the overall data will show that on the discharge, 90%, 9% patient have only secretion problem, and 89% have discharged well. So this is the effectiveness of the respiratory rehabilitation and respiratory therapy in esophagectomy. So complication and rehabilitation resolve within 5 and plus minutes or 1 day, and ICU stay, overall our ICU stay is due to respiratory rehabilitation. These are 2 plus minus 1, and hospital stay is around about 7 plus minus 3. So this is the overall of our outcome. And the summary overall there, secretion retention cause the most problem, significant gender, BMI, and airways related to risk factor that are causing the more respiratory complication. Rehabilitation improve the recovery and the discharge. And clinical implication, early respiratory rehabilitation and ICU stay improve the outcome. And pre-operative breathing training is essential in esophagectomy cases. So this is the research team which is involved in all of these scenario taking in the research. And next we have a goal on this. Early, we want to further study. So this is not the stop of our study. We want to further study early predictor involve the respiratory complication in esophageal carcinoma. And we want to more now explore evaluate the real-time spirometry impedance and diaphragmatic ultrasound for early detection of decline. Also, another topic we have the molecular link now with the esophagectomy and other factor and collaborative registered comparative short and long-term respiratory outcome across the surgical and rehabilitation program and effectiveness of mucolytic inhalation therapy in post-esophagectomy. So these are all of the future program we want to do in the esophagectomy patient in overall improvement that data in the Pakistan. So thanks. So these are the reference we have included.
Thank you for the nice presentation, Dr. Abdullah. Do we have any questions from the speaker?
Do you think the difference you observed in complications between patients with squamous cancers and adenocarcinoma might just be related to the different location of the tumors?
I have observed the difference between squamous carcinoma and adenoma. This is a good question. Thing is that when you are treating the patient squamous cell carcinoma with respiratory complication adenocarcinoma, the data show that the patient is a adenocarcinoma, they have more complicated as compared to squamous cell carcinoma. So these are the main we have challenges. So that's why we have planned our hospital plan a very comprehensive respiratory rehabilitation program. And we have started from day 1 to day of discharge. And that's why our the outcome, clinical outcome improve now. So when you look the worldwide data, so even the Pakistan data, when you look at our data, is the big difference between the international data and the local data. Now, before the local data, the respiratory complication is around about 63%. And the international data, respiratory complication is 60%. But in our data, we have categorized the patient in the two groups, namely squamous cell carcinoma and then we have evaluated the complication in the both group. And our rehabilitation program show that we have improved overall respiratory complication, and day 6, the respiratory complication goes to only 8%. So this is the and overall when we look on the day 1, day 2, and day 3, the respiratory complications at that time 29%, but none of the other patients is worse and increase the more oxygen requirement. So this is the beauty of the over rehabilitation program. And I thought Nabi, I have traveled in the different country like UK and USA. I have presented the research, but our data, as the data is the database, I think the data is the data which is showing the real situation, what is happening in our hospital, and we are the competing the international standard.
Okay, thank you. So now I would like to invite the next speaker, Dr. Muntaha, evaluating FDG PET-CT versus tissue biopsy in progressive Hodgkin's lymphoma, diagnostic accuracy for detecting relapse sites.
Assalamualaikum everyone. I'll be presenting evaluating FDG PET-CT versus tissue biopsy in progressive Hodgkin lymphoma, diagnostic accuracy for detecting relapse sites. I have no disclosures. This is the brief layout of my presentation. As we all know that lymphoma is one of the major pediatric malignancies, accounting for approximately 7.5% of the cases. Its incidence rises with age, being highest in the 15 to 19 years of age group. Despite excellent treatment options, significant percentage of patients show resistance or relapse requiring salvage therapy, and disease progression is based on FDG PET-CT scan findings and the biopsy of the most palpable or avid site. As per NCCN pediatric Hodgkin lymphoma guidelines, PET-CT scan is recommended in the staging as well as response evaluation and in restaging of suspected relapse. So on PET-CT scan, response is documented as based on dual scoring system, which is a 5-point scoring system, and progressive or relapse disease is documented as dual score of 5. Whenever there is progression on PET-CT scan, biopsy is always performed for two major reasons. One, to confirm the relapse or progression, or to see tumor transformation. But tissue biopsy is an invasive and time-consuming modality. Which brings us to the objective of my study, that is to compare FDG PET-CT scan findings and biopsy results in progressive or relapsed Hodgkin lymphoma patients, and to assess if PET can obviate the need for tissue diagnosis. It was a retrospective study of biopsy-proven patients of pediatric Hodgkin lymphoma from February 2022 to June 2025. A total of 75 biopsies were performed in 60 patients, and there was no treatment in between the PET-CT scan and biopsy. So we looked into the demographics, initial histopathology, sites of disease progression on PET-CT, biopsy site and its results, and the standardized uptake value of the biopsied lesion. Coming to the results, 60% of my population were males, rest females. 68% of the patients were more than equal to 10 years of age. Based on histopathology, classic Hodgkin lymphoma was the most common subtype, and the biopsy results were classified into 4 categories. As 86% of the biopsies were positive without any change in type of lymphoma. And 8% of the biopsies turned out to be reactive. 3% of the biopsies showed tumor transformation into another type of cancer, and 3% of the biopsies were inadequate, requiring the patient to go through an additional process of biopsy. So when we compared the standardized uptake value of the disease and non-disease sites, we see that the disease sites has SUV max range from 2.6 to 18.9 with a median of 6.3, but the non-disease sites had SUV max range from 1.9 to 4.4 with a median of 2. And we see an overall higher SUV max range at disease sites. A few cases from my data. This is a patient with classic Hodgkin lymphoma on third-line chemotherapy. PET-CT scan was highly suggestive of progressive disease in the large sternal mass, and the biopsy confirmed the case. Another patient with classic Hodgkin lymphoma suspected relapse. PET-CT scan detected multiple sites of disease and suggested progression. External iliac node was targeted for biopsy because of its accessibility, and which confirmed the case. This is an interesting case of 8-year-old male with classic Hodgkin lymphoma, suspected relapse. PET-CT scan was performed. We see disease at multiple sites in the mediastinum, abdominal, and marrow uptake in the left iliac bone. But because of the accessibility, mildly avid cervical nodes were targeted for biopsy. But the biopsy came out reactive. So as PET was highly suspicious for disease, avid disease, so they performed a bone marrow biopsy on this patient, which also came out to be negative. Then they performed a targeted biopsy of the left iliac bone lesion, but it failed to reveal any malignant cells. So they held an MDT discussion for this patient, and they suggested to repeat PET-CT after 3 months. So unfortunately, when the PET-CT scan done after 3 months, it showed disease progression in the mediastinal abdominal nodes, multiple new pulmonary and marrow uptakes. And finally, they decided to go for a biopsy of the subcarinal node, which eventually confirmed disease relapse. So this patient finally started on second-line chemotherapy 6 months after the first PET-CT suggested relapse. Another patient with classic Hodgkin lymphoma on third-line chemotherapy suspected relapse. This patient had multiple bilateral cervical nodes. We suggested in a PET report to go for a biopsy because they were mildly avid, and the biopsy came out to be reactive. Another patient initially diagnosed with diffuse large B-cell lymphoma, and follow-up PET-CT scan showed interval development of left omental nodules, and we suggested to go for a histopath correlation, and that turned out to be Burkitt lymphoma, and this patient showed tumor transformation. Coming to the literature review, this study, a very own institutional study, which compared FDG PET-CT scan findings with bone marrow biopsy results, and they concluded that FDG PET-CT is more sensitive than bone marrow biopsy for bone marrow involvement detection in pediatric Hodgkin lymphoma. And other study which compared PET-CT scan versus bone marrow biopsy in multiple pediatric malignancies also suggested that it has high sensitivity when assessing marrow infiltration. I am going to highlight this article. I am going to highlight the importance or the process the children have to go through when they go through the process of biopsy. So there are multiple factors that are involved, like lymph node accessibility, anesthesia, risk, resource availability, and the expertise of the person who is performing the procedure. So, in my opinion, bone marrow biopsy should only be considered in those pediatric patients where the PET is indeterminate or inconclusive, because it's a hectic process to go through, and for multiple times it's a challenge. So to conclude, PET-CT scan has accurately diagnosed relapsed and progression in more than 86% of the pediatric Hodgkin lymphoma patients, and hence in those patients, biopsy did not alter management. And not all pediatric patients with progressive or relapsed disease need an invasive procedure like biopsy for confirmation. Thank you for your patient listening. I'm open for any questions.
Thank you. Thank you for the nice presentation, Dr. Manta. Questions for the speaker?
I have one question about this. You have told that 86% is like the sensitivity. What is the sensitivity and specificity overall of your data?
We unfortunately were unable to calculate that scientifically, so I can't really tell you about that.
Okay.
So, what are your future recommendations based on the data?
So I would recommend, as when we report a PET CT, so we know when to go for a biopsy. That I showed the cases when we actually recommended to go for a biopsy in the cervical nodes case. So when the reporting physician tells you, then you should only go for the biopsy. Why to make the child go through the same like difficult and tenuous process again and again when the PET is highly suggestive of biopsy? So I would recommend biopsy should be done in those cases where the PET is indeterminate or inconclusive, when we are like suspicious that the biopsy should be done.
Okay.
All right.
Dr.
Not
Manta,
all patients.
I have a question.
Yes, sir.
If have you worked out, or you think there can be a SUV cutoff or a metabolic cutoff where you can suggest to go for a biopsy or to avoid one?
Sir, वैसे overall the disease sites had high biopsy SUV max range, but there were some indeterminate results because there were some of the lesions that were showing low SUV max, but they were disease positive, and a few that were showing like a moderate SUV max, but they were reactive. So I can't really tell about the cutoff, but I can say with the CT findings and PET avidity, both the things we can say this site needs to be biopsied, and this is for sure our disease.
Yeah, exactly. Because basically at the moment, FDG is used to establish if there's a site and to suggest the biopsy. What you are suggesting is to avoid the biopsy. For that, NucMed will have to come up with a criteria as well.
So because they are already diagnosed cases of pediatric Hodgkin lymphoma, so I am saying once they are diagnosed, so
Sorry. What's your understanding? Why do they do a biopsy?
so that's because they need to see that they need to see any tumor transformation, or they need to see whether it is the disease which is progressing or it's something else, or it may not be the disease.
Exactly. So what the hope is that there should be a imaging-based answer to predict the cases which are transforming versus those which are not. Thank you very much.
Thank you.
So now I would like to invite the next speaker. Role of FTG PET in the management of primary central nervous system lymphoma, Dr. Tabir Saghir.
Assalamu alaikum. My name is Tabir Sahir, and I'm going to present role of F18 FTG PET-CT in the management of primary center nervous system lymphoma. I have no disclosures. This is a brief layout of my presentation, that how it's going to be. Moving to the introduction, most of us already know that it's a rare and aggressive form of lymphoma, mostly presenting as DLBCL. The key modality that we use in standard practice is MRI, but atypical presentation can certainly pose some difficulties and challenges. So there comes the objective of my study. It is to evaluate the role of F18 FDG PET-CT in the staging, diagnosis, and response assessment of primary center nervous system lymphoma. Coming to the study design, this is a retrospective study. It was done between April 2010 to May 2025. 84 FDG PET-CT scan of 48 patients were evaluated. It included all age groups, both gender, staging, restaging, and follow-up scan. And demographics, the parameters that are included was demographics, Ki67 index, nodal and visceral involvement, SUV max. Coming to the results, mean age of patient was 46 years, plus minus median that's written over there, with most of the population was male and 42% females. The coming to the histopathology, as I described earlier as well, that the most common presenting is DLBCL, and in my study it was the case as well, with 76% DLBCL, and the least of all was Hodgkin lymphoma with 2%. The rest of them is displayed in the pie chart. Coming to the staging scan, total number of staging scan we had was 48, and out of which 57% underwent the surgery and showed 57% as well showed the residual disease. Coming to the restaging scans, there were 44 restaging scans, and out of which most of them showed complete metabolic response, followed by the partial metabolic response, and the least of them was progressive disease, which is 15%. Further categorizing the progressive disease, we had least of them was osseous lesion and the equal amount of nodal, local, and multiple region relapse, as shown in the chart as well. Coming to the results of progression-free survival, we calculated the progression-free survival on the basis of gender and Ki67 index. Ki67 index was more than 70% and less than 70%, and the more than 70% we had 56 months, and in less than 70% was 68 months. It was not statistically significant with the p-value of 0.8, and it was comparable between the gender. For the males, it was 54 months and females 65 months with the p-value of 0.3. It's shown in the curves as well. And the overall survival difference between these two groups was not statistically significant as well. So coming to the interesting cases that I included in my study. First case, 27-year-old female presented with headache, vomiting, and vertigo. These are the most commonly presenting intracranial lesions symptoms, and it turned out to be DLBCL with Ki67 index of 80 to 90%. And the FDG PET-CT scan showed avid enhancing lesion in the left frontal lobe with SUV of 72, as shown. The second case is 43-year-old female presented mostly with this similar symptoms, and its FDG PET-CT showed avid enhancing lesion in the right frontal lobe with craniotomy defect in the left frontal bone with SUV of 29. As I described earlier in my results that most of them showed complete metabolic response, it's one of the case, and 43-year-old male underwent staging and restaging scan. These three pictures shows the staging scan, and it's avid enhancing lesion in the left frontoparietal lobe with adjacent vasogenic edema. And in the restaging scan, we can all show it complete metabolic response. Another case, 52-year-old woman underwent PET-CT scan for the DLBCL, and it showed avid hyperdense lesion in the right thalamic region, and it also showed the mediastinal nodes, which are pointed by the arrows. Coming to the discussion, the article that I have included is utility of FDG PET-CT in the primary center nervous system lymphoma and its contribution to prognosis estimation. It was published in Gohan Medical Journal in 2017. And it actually, the disease-free survival for this article was, in the first year was 47%, the second year was 31%, and then it concluded the utility of FDG PET-CT can be summarized as initial diagnosis, baseline staging, and restaging and evaluation of treatment response and prognosis estimation in primary center nervous system lymphoma. The SUV max certainly is a strong predictor for the progression and survival of the disease. The next article that I included is the contribution of metabolic parameters of FDG PET-CT prior and during therapy of adult patients with lymphomas. It was published in 2020, and this study actually suggested the metabolic tumor volume, and total leukocyte glycolysis prior to immunotherapy. And actually, it allows us to predict the response or not to the treatment that patient is going to receive and the determination of poor or favorable survival. Coming to the conclusion, so hereby my study concludes that the F18 FDG PET-CT is an important diagnostic tool for the staging and restaging purposes, and it can certainly aid in the treatment evaluation, and it can facilitate the detection and of residual or progressive disease. It's not yet included in the major clinical guidelines, but yet we can hope so. It will be included soon. Thank you so much.
Thank you, Dr. Avid, for the presentation. Do you have any questions from the speaker? Why do you think it's not included in the guidelines?
It is, I mean, I studied it, like it is in the articles, but it's not like the key modality, or certainly we go for the first thing. Certainly MRI is the first thing that we go for these scenarios.
Yes. You see, it's not that that's the first thing. It doesn't replace the MR. That's the only thing. Okay. Any other comments? Right, thank you.
Thank you.
So now we go to the next speaker, Dr. Shaila Tanveer. The topic of Dr. Shaila's talk will be prognostic utility and inter-rater reliability of PET-CT quantitative parameters for disease-free survival in HCC treated with TACE.
Assalamu alaikum, good morning, respected panel and dear audience. I am Shaila Tanveer, and I'm very pleased to share our research titled Prognostic Utility and Inter-Rater Reliability of FDG PET-CT quantitative parameters for disease-free survival in HCC treated with TACE. The study is done in collaboration with my co-authors, Dr. Maruk Latif, Associate Professor from University of Lahore, and Dr. Muhammad Numair Yunus, Consultant Nuclear Medicine at INMOL. So in the coming few minutes, I'll take you through the background and the problem statement of our research, the methods employed in our study, and the results that we acquired, and how do they compare with the existing literature. So HCC is the sixth most common cancer throughout the world, and its prevalence in Pakistan is reported to be 3.0 to 7.6% in the Pakistan in patients with CLD, with HCV being the most responsible factor in it. Unfortunately, less than 30% of these patients are eligible for the surgical treatment, mostly because of the intermediate to late stage of the cancer at the time of diagnosis and the existing comorbidities. So that is where the TACE, transarterial chemoembolization, comes into the picture, as it is a palliative procedure that works by delivering chemotherapy directly to the tumor cells and blocking the feeding artery by the help of the embolic agents. 18-fluorodeoxy PET-CT scan is an imaging test which provides critical insight into the tumor metabolism and biology, unlike any other conventional imaging. So the rationale of our study is that the utility of PET-CT quantitative parameters for the prediction of the disease-free survival and treatment response in HCC treated with TACE is an area of research that is very much under explored. And the studies that have already been done mostly just rely on the baseline standard uptake values without taking into consideration the standard uptake values from the follow-up PET-CT during the treatment. So this brings us to the objectives of our study. The objective of our study was to evaluate the prognostic utility of the 18F PET-CT parameters in determining the treatment response and disease-free survival among patients of HCC that had received the TACE. The second objective was to assess the interradiologist agreement on their interpretations of the baseline SUV for predicting the treatment response. So our study had a sample size of 38 patients from both genders, from the age group of 30 to 75, who had no prior history of TACE, radiotherapy, or chemotherapy, and had a conserved and preserved liver function. However, the patients that had diffuse HCC lesions or had a concurrent malignancy or major organ dysfunction were excluded from this research. 18 fluorodeoxy PET CT scan, a baseline, and a follow-up scan was done. The baseline scan was done 7 days prior to the TACE, and the follow-up scan was done at an average of 2 months later than the TACE. Both baseline and the follow-up scans were done on the GE Discovery MI Gen 2 PET CT scanner. The radio tracer was injected intravenously in the dosage of 5.5 megabecquerel, and then the patient was asked to rest for 45 minutes and was then placed into the PET CT scanner. So the quantitative parameters that we assessed in our research was tumor standard uptake values, the delta TSGB max, and its derivatives delta TSGB max percentage and delta TSGB mean percentage. So we defined the treatment response according to the PET response evaluation criteria in solid tumors, PERSIST. And according to this PERSIST criteria, lesions that showed a 100% decrease in metabolic activity were defined as the complete response. Lesions that had at least 30% decrease in the metabolic activity were defined as a partial response, and those lesions that showed a 20% increase in metabolic activity were defined as progressive disease. So patients that showed a complete or partial response were put into the category of responders, and those who had a stable or progressive disease were put into the category of non-responders. Our study defined disease-free survival as the time period between the first TACE to the date of last follow-up, either last follow-up or the date of recurrence, or the change of therapy or the demise of the patient. So in our study, the mean age of the patients turned out to be the 52 years. And the mean disease-free survival in our study was 11.92 months. And according to PERSIST criteria, our study had 29 patients belonging from the responding category and 9 patients from the non-responding category. To assess the inter-rater agreement, we performed Cohen's kappa test, which showed that there was a moderate but statistically significant agreement between the radiologists in categorizing the treatment response. So to talk about how well the PET metrics performed in predicting response group, we performed a discriminant function analysis, which showed that all PET metrics were significantly different in the two groups of responders and non-responders. However, the delta TSU max turned out to be the strongest predictor of them all, showing an excellent classification capacity with a clear distinction between the two groups of responders and non-responders. We also took into the consideration the blood marker delta AFP percentage and performed a binary logistic regression test to see if the parameter can predict the treatment response reliably. The test shows us that the delta AFP was not significant and it could not alone predict the treatment response in a reliable manner. However, the delta TSU max was a significant predictor. For the disease-free survival prediction, we had a binary classification of DFS less than 12 months and the other group that had a DFS of 12 or more than 12 months. The ROC curve analysis showed us that the delta TSGB max was the strongest predictor of them all. The rest of the PET metrics and the delta AFP was the weaker predictor. Delta TSGB max offered an optimal cutoff value of 3.3 and more than that, with a sensitivity of 70% and specificity of 78%. This is the ROC curve for delta TSGB max. The farther the curve is from the reference line, the better they are in their prediction. And as you can see, this curve for delta TSGB max is quite far from the reference line. This is the combined ROC curves for all the metrics, and the curve for delta TSGB max here is annotated in the green color. And as you can see, it is the farthest curve from the reference line, showing that it is the strongest predictor of them all. So how do our studies compare or contrast with the existing literature? There has been inconsistent metrics that have been analyzed throughout the literature. Some took into the consideration the SUV ratio, some took into the consideration the delta TSUV max percentage. Our study took into the consideration the most clinically used parameter, that was delta TSUV max and its parameters. We had another point of strength that we also included the blood marker delta AFP to compare its prognostic capacity with the prognostic potential of the PET metrics. Similarly, the endpoints have been inconsistent, but the strength point of our study is that not only it had the short-term endpoint in the form of treatment response, but it also had a longer-term endpoint in the form of disease-free survival. The cutoff values has been reported for different parameters in different studies. Our study showed the cutoff value for the delta TSGB max. Despite these contrasting features, our study does compare with the study of Ma W et al. On the fact that both of these studies, theirs and ours, shows delta TSGB max percentage to be the strongest predictor of the treatment response. So to conclude, our study showed that the delta TSGB max is the strongest predictor for the disease-free survival, and the delta TSGB max percentage is the strongest predictor for the treatment response groups, outperforming the blood marker delta AFP percentage. This is the case image for a patient that showed a hypermetabolic lesion in the right lobe of liver prior to the TACE. Following the TACE, as you can see, there's a remarkable reduction in the metabolic activity, both in the fused axial image and the PET-only axial image. Thank you so much. That's all from my side. I'll be happy to answer any questions that you might have.
Thank you, Jana. You have any questions for the speaker?
Assalamualaikum. Considering that HCC exhibits a low FDG avidity, what was your cutoff for labeling alien as a complete metabolic response? Like, was it liver or like what was your cutoff?
So basically, the cutoff that we had of the delta TSGB max, it was 3.3. So patients that had more change in the metabolic activity than 3.3 SUV max were more prone to have a complete response, complete or almost complete response.
It was a retrospective study, no? So,
yes.
So like while you were reporting the PET, so did you label it completely like responded solely on the base of PET, or you performed contrast enhanced CT with PET?
So basically, in the procedure, the contrast enhanced CT also happens, and then the PET also happens. But the criteria that we chose and we decided to stick to was the delta TSGB max, as we were entering the values for our data sheet for this research.
Thank you.
Welcome.
Thank you. Oh, we have a question. Sorry, you have a question.
Although you showed us that observers don't always agree about response, you didn't really, I don't think you really showed us whether there was a difference in outcome where patients agree, where the observers agreed and disagreed.
So basically, when we talked about the interdata agreement, was that the radiologists were given the PET CT scans. They individually read the images. They individually came up with the assessment of standard epic values. And then on those baseline SGB values, they made their predictions on whether the patient would be in the responding category or the non-responding category. And that is what we compared, the predictions of the radiologist 1 and the second radiologist that they made on the baseline SGB values.
Thank you.
Thank you so much.
The next speaker is Ishan Sikandar, and he'll be talking about prognostic value of disease distribution and SUV max in Langerhans cell histocytosis, correlation with event-free survival and overall survival.
Assalamu alaikum, everyone, and a very good morning. I'm Dr. Zishan from Nuclear Medicine Department, SCAM. The topic of my presentation is prognostic value of disease distribution and standard uptake value max in the Langerhans cell histocytosis, correlation with event-free survival and overall survival. Langerhans cell histocytosis is a rare disorder in which there is abnormal proliferation of CD1A positive and CD207 positive myeloid dendritic cells occurs. BRAF V600 mutation is present in half of the cases, and activation of MAP kinase pathway is a key driver of this neoplastic disorder as shown in this diagram. It presents a single system or multi-system disease with risk organ and critical organ involvement. In 80% of patients, most common organ involved is skeletal system, followed by skin and pituitary. Along with the histological and immunophenotypic examination, diagnosis of LCH is also based upon various radiological features. Among various available imaging modalities, whole body FDG, PET-CT is becoming a valuable tool in the assessment of LCH as it identifies both osseous and extraosseous lesions. The objective of our study is to evaluate the prognostic value of disease distribution pattern and metabolic parameter of baseline FDG PET-CT, that is SUV max in children with LCH. We retrospectively analyzed the data of 63 histopathologically confirmed LCH patients who had FDG PET scan from August 2013 to August 2025. Study protocol was approved from Institutional Review Board. The patient age range between 1 to 18 years with male predominance, 63% were male and 23% were female. Baseline FDG PET-CT metabolic parameter, that is SUV max, and pattern of disease distribution were correlated with the survival rate. Total patient were 63, single system LCH patients were 32 and multi-system LCH 31. Risk organ were positive in 12 out of 31 patients, while risk organ were negative in total of 19 patients. 51% patient has single system involvement, while 49% has multi-system involvement. Risk organ was involved in 38%. Predominant risk organ involved were liver and spleen, followed by bone marrow. Diabetes insipidus was diagnosed in 10% of the patient, in 15% of the patient. On follow-up, remission was seen in 74% of the patient, while reactivation seen in 9.5%, while 15% had progressive disease. Those who had progressive disease died eventually. Mean value of SUV max in died patients were 6.7 plus minus 1.8 standard deviation, while those who survived had SUV max of 4.7 plus minus 3.0 standard deviation with a p-value of 0.01. As p-value was less than 0.05, so it shows the significant statistical difference between alive and died group. This is the 10 years event-free survival in patient with single system LCH versus multi-system LCH. In single system LCH prognosis, 10 years event-free survival was better, representing 90%, while in multi-system LCH, 10 years event-free survival was 60%. 10 years overall survival in single system LCH was 93%, while 10 years overall survival in multi-system LCH was 72% with p-value of 0.04. 10 years overall survival in risk organ positive LCH, multi-system LCH was worse than risk organ negative multi-system LCH, that is 50% versus 74%. This is the case, 10 years of age male patient with multi-system LCH involving cutaneous lesions as shown in the PET-only image and the fused image, lymph nodal involvement as shown in the diagram. Inguinal lymph nodes are involved and pulmonary system involvement. Chemotherapy was given to the patient according to LCH4 protocol 2015. End of treatment scan shows good treatment response with interval resolution of cutaneous, inguinal, and pulmonary lesions, and no new site of disease was identified. Another patient, 6 years of age female patient with extensive FDG avid disease involving the brain, left temporal lobe, right occipital lobe, a lesion in the spleen, lesion in the liver, bone marrow, and lymphoidal involvement. Coming to the discussion, recently roll up metabolic imaging, that is FDG, in a patient with LCH is evolving as it provides both anatomical as well as metabolic activity of the lesion in a single scan. Survival rate, both event-free and overall survival in single system LCH is better than multi-system LCH. Survival rate in multi-system LCH with risk organ positive is worse than those with risk organ negative, as the results of our study shows 50% versus 89%. prognosis of LCH in children has been improved significantly with the current standard treatment protocols. However, progression and relapse are still challenges, especially in those patients with risk organ involvement. Some of the supporting studies, Joseph et al. Studied 33 patients and stated that FDG PET CT had a high sensitivity in staging and follow-up of patients with LCH having very low false positive rate. Chern et al. Also stated in his study 100% 5-year event-free survival for patients with single system LCH. Study conducted by Liu et al. Stated that baseline FDG PET CT metabolic parameter could help to predict disease outcome in pediatric LCH. So to conclude, event-free survival and overall survival was significantly higher in single system LCH versus multi-system LCH. Event-free survival and overall survival in risk organ positive patients were worse than those with risk organ negative patients. Baseline metabolic parameter, that is SUV max, is a promising imaging parameter for predicting prognosis in pediatric population having LCH. So my recommendation is baseline SUV max can be incorporated in the risk assessment of the patients with LCH. Thank you all.
Thank you, Dr. Sham. Do you have any questions from the speaker? Anyway, there are no questions. Thank you. All for the session. The last speaker, Dr. Atka Mariam, is not here. No. Right. So that's all. Thank you very much for the session. Thank you.